I'm Dr. Christoph Correll, Professor of Psychiatry and Molecular Medicine at Hofstra North Shore LIJ School of Medicine in Hempstead, New York. With me is Dr. John Kane, Chair, Department of Psychiatry at the Hofstra North Shore LIJ School of Medicine and the Zucker Hillside Hospital, and Dr. Nasir Gami, Professor in the Department of Psychiatry and Director of the Mood Disorders Program at Tufts Medical Center in Boston, Massachusetts. We're here today in Toronto attending the 168th American Psychiatric Association annual meeting to discuss highlights from the conference. So, John, this has been a very lively meeting, and one of the areas that has gotten a lot of coverage is really psychedelics, ketamine, marijuana. Can you maybe summarize some of your impressions of those presentations?
Sure. Well, I think it is a very exciting area. We're seeing a resurgence of interest in some of these compounds. There are studies now of psilocybin in treating cancer patients. We've seen the medical use of marijuana now in several different indications. We need a lot more research, but I think it's good to see a kind of a resurgence of interest in learning more about these interesting compounds. Ketamine is being used now to treat depression, and obviously we still have a lot to learn about that, the long-term use, et cetera, but I think it's very exciting.
Now, in the US, there has always been like a pushback to any research with these agents because there was the feeling that would maybe legalize something that can be bad for the brain, or there are other biases. So what's your take on that? Why is there a change, and can that really help science and patients ultimately?
Well, I think we have to separate the politics from the science and make sure that our political decisions are informed by data and evidence. And I think that's been lacking in recent years. I think we need much more information that people can use. And, you know, there are always risks and benefits. I mean, we have compounds that might have abuse potential, but might also have some very valuable therapeutic indications.
Yeah, and the point, in fact, is marijuana, where the THC might actually promote psychosis, but some other compound, cannabinoid, might be antipsychotic.
Exactly.
Nasir, what's your take on that area?
Well, I think that a lot of the discussion is in this conference is probably being driven by the fact that marijuana is getting legalized in different states medically, and in some cases in general. And I think it's just raising questions in the field of is this good or bad, and how is it going to impact practice? And I think there is some concern out there that it may increase the rates of substance abuse, or may cause more problems than not, which we may not be able to predict ahead of time.
All right.
But it does provide an opportunity for us to study those things and perhaps learn who's vulnerable to abuse and who's likely to get some therapeutic benefit.
Right. Now, another topic has been cultural differences. Obviously, you can interpret marijuana and other uses culturally, but also the expression of psychiatric disorders. So what's your...
Well, I know there was a presentation talking about differences in the way depression is diagnosed in different countries, and I think it's true that in some cultures, people are much more likely to focus on their somatic complaints when they're depressed, rather than talking about feeling down or feeling sad. So I think we as psychiatrists need to be sensitive to the differences, and when we interview patients, and certainly the United States now has people from many different cultures, so when we interview patients, we need to be sensitive to the different ways that depression might present.
Right. Nasir?
I think it's another example where cultural change is impacting the conference. I mean, we obviously are becoming a much more multicultural society. And I don't think there's new groundbreaking data about cultural differences at this conference, but I think there's just more awareness that it matters. And I think that's relatively new.
Yeah, and so for example, ataque de nervios in some of the more Hispanic populations that interpret anxiety and depression differently. I think clinicians need to be aware of that. And I guess we need to also train our residents more in that cultural awareness. And DSM-5 has also put some more emphasis on that. So I think we're all going in the same direction, that the brain and its expressions are varied based on the environment where the people are.
And we also hope to enhance mental health literacy so that people from different cultures can understand what mental illness is, what it might mean for them or their family, and so we can have a more informed discussion.
Right. Now, another area has been psychodynamic psychotherapy. It's a little bit strange to see so many of these presentations at this meeting because it's been such an old and often accepted kind of treatment. But there are also other psychotherapeutic advances. So what's your take on the psychodynamic and what's being shown here?
Well, there's certainly a lot of continued interest in psychodynamic psychotherapy amongst many of our colleagues, but I think there's also been a burgeoning interest and awareness of some of the more of kind of specialized psychosocial interventions, cognitive behavior therapy, et cetera. And I think, we certainly need to try to deliver evidence-based treatment to our patients, and to be flexible and eclectic, and understand that certain kinds of therapy might be appropriate for certain kinds of patients.
Yeah.
Yeah, I think what we're seeing is something that's descriptively interesting for the profession, which is that there are many meetings and discussions around psychodynamic, psychoanalytic approaches in psychiatry, and it's not going away. For good or for ill, that can be debated. But certainly there must be some benefits that clinicians see in practice in different kinds of ways that lead them to continue to be interested in psychodynamic approaches and personality conditions and so on. And I think there is a need for more research to really clarify when we should be able to be using these conditions and when less so, and other, not even just biological conditions, but other psychotherapeutic approaches. But it is descriptively interesting that there is a large interest that continues in psychoanalytic approaches in our field.
Yeah, I mean, it's clear that our medications have limitations, the psychotherapeutic approaches have limitations, and we need more subgrouping of who benefits from which approach and which combination. So I think it's important to see that some of the schools are maybe becoming a little bit more open to choosing different techniques from different approaches in order to really not have only the patient match a certain therapy, but the therapy to match the patient.
And also, as you implied, the integration. So we may have a combination of medication and a certain type of psychotherapy or psychosocial treatment. And I think for many conditions, it's that combination, that integration that's really important.
Right. So it's interesting that we see a lot of psychodynamic understanding-based kind of presentations, but on the other end of the spectrum, we're also getting much more now medicine joined with psychiatry, so that we're not just talking about the brain, but the body. Nasir, you were also part of a presentation or a symposium. Maybe you can share some of those directions where the field is going.
Right. I think that's definitely a central theme to this conference. I was part of organizing a presidential symposium on the mind and the body, how the body affects the mind, how the mind affects the body, and I got a lot of interest, and there were multiple symposia on that topic, which are driven a bit by the current president and the scientific committee's interest this year to emphasize this topic. And a general theme is the concept of inflammation in the pathophysiology of depressive illness in particular. So there's a lot of research that's discussed, for instance, on how insulin receptor sensitivity is an important aspect of the pathophysiology of depression in the brain. So we think about that in the pancreas and diabetes, but it's actually just important in depression in the brain. And of course, the conditions get linked. If you have diabetes, you're more at risk of depression. If you have both, you're more at risk of dementia, all of which is part of the same neurotoxic pathophysiology, essentially, that happens with a lot of inflammation in the body. There was some research presented on looking at non-steroidal anti-inflammatory drugs for treatment of depression, meta-analysis that was done that suggested some benefit, and then a discussion about how maybe that meta-analysis might not have taken into account limited benefit in some ways. The general consensus was that probably non-steroidals as a whole aren't effective for depression, but that there are more subtypes of depression where there's a lot of inflammation. And the suggestion was, for instance, a C-reactive protein that's above 5 may be a predictor of an inflammatory kind of depression that, in fact, in one study responded some to interferon. But if you take major depressive disorder, quote unquote, as a whole, interferon was no different than a saline infusion for all of them.
Right.
So it gets back to the concept of differentiating subtypes of illness as opposed to general large groupings.
Right. Inflammation is currently so much in vogue, and it's been shown to be higher in almost all conditions where it was looked at. It's not just depression, bipolar disorder, schizophrenia, PTSD, OCD, suicidality. Now, a lot of these psychiatric disorders are associated with more higher BMI, smoking, conditions that actually can jack up the inflammation. So we did a meta-analysis in anorexia patients where the BMI is much, much lower. And again, we found more inflammation, IL-6, for example. So it seems to me that this can't be specific. It's most likely more a non-specific vulnerability marker that might bring out some of the other genetic underpinnings. But if we can lower that stress that's coming or that's bringing out some of the psychiatric disorders, that might help a certain subgroup that's especially in the inflammation area, might help the treatment. So I think it's important for us to bring those two things together. But another topic that's been also discussed is obviously the medical illness and the mentally ill, and how can we deal with that? And I think nowadays the integration of care is very important in order to reduce morbidity and mortality. John, what's your opinion on that?
Oh, absolutely. Well, some of the work that you've done on the metabolic side effects of antipsychotic drugs, I mean, we need to be able to prevent some of the consequences of our own treatment in terms of impacting people's medical well-being. We need to help people with smoking cessation, et cetera, et cetera. So I think, there has not been enough attention devoted to integrated care, whether it's providing the primary medical care that people with mental illness need, or providing the psychiatric consultation that people with medical illness need also. And we've certainly seen with the emphasis on cost containment and affordable care, et cetera, I think there's an increasing recognition that if someone has a medical condition like congestive heart failure or diabetes, but they also have depression or substance abuse, that adds a tremendous amount to the cost and to the challenge of treating them. So we need to make sure that we're working very closely with our medical colleagues to make sure that everyone is getting the kinds of integrated care that they need.
All right. Nasir?
Well, yeah, I think that this general concept that medical illness is connected to psychiatric illness is really important and increasingly recognized. So in our symposium, for instance, I presented a systematic review we did on lithium in prevention of dementia. And it turns out if you have depression or bipolar illness, your risk of dementia is probably fourfold higher. And according to various studies, lithium may be quite protective of that, epidemiologically at least, and including 4 or 5 randomized studies now that have started to suggest that. This could be an important thing, obviously, for Alzheimer's dementia and vascular dementia as well. And a relatively simple intervention, potentially. Toxicities can be limited with low doses, it seems. And then another aspect of this is mortality due to cardiovascular disease. Most people don't realize that the main cause of death for affective illness, for instance, is cardiovascular mortality, not suicide. Right. Suicide is the highest relative risk, but cardiovascular also goes up, and that's the most common cause. So we had a review of some of the SRI literature that suggests perhaps some reduction in mortality. There's also lithium data in the general populations that show reduction in cardiovascular mortality. So I think we're coming back to the notion of saying not just how can we make your mood better, for instance, in a patient with manic depressive illness, but how can we keep you alive as well? Right. That's just as important.
So psychiatry is really a medical specialty again. Yes. We're getting that resurgence also. Right. But then there's also integration of care between, as we said earlier, medication and psychosocial interventions. And I mean, you're the PI of the RAISE study, where this has been very important to try to maybe change the trajectory of the illness. Maybe we can end by just reviewing that a little bit.
So we've had 2 symposia here at the APA on the RAISE project, which was an NIMH-funded program to try to improve the trajectory of early phase schizophrenia. But one of the key elements was integrating psychosocial and psychopharmacologic treatment. So an emphasis on individual therapy, which we called individual resiliency training, family psychoeducation, family therapy, supported education and supported employment, as well as psychopharmacologic treatment, and all team-based, focus on shared decision-making, et cetera. So we did see a significant impact on quality of life and the portion of young people working or going to school. So we're pleased with the results of that, and there's a lot more interest now in setting up programs across the country to facilitate the early identification and treatment of people with psychotic disorders. So that's very welcome.
And I think it's important to point out that quality of life was the primary outcome. So it's not our usual symptom-based treatment or even recovery, but it was very much patient-centric. And also that, although it sounded like a lot of interventions, the impetus was to deliver this in usual care settings and under current reimbursement structure so that it can actually be translated into usual care settings.
Exactly. So we worked with 34 community clinics in 21 states across the United States. So, that's a key element, because if we develop a comprehensive care model that can only be delivered in an academic center with a lot of additional funding, it's not really going to help the people who need the treatment.
And it's wonderful that NIMH actually put such an emphasis on the early phase and supported this.
Yeah, absolutely.
Any final word about the meeting before we end, Nasir?
No, I think we've covered pretty much everything.
Okay, John?
No, thank you very much.
Okay, thanks very much to the 2 of you. And also thanks to you listening to this, and we hope to see you again at a different program. Take care.